بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we will continue the series of female pelvic imaging, and this is the second talk in this domain. We have finished with the uterine anomalies, and we discussed also the issue of uterine leiomyomas, and now we are discussing the issue of uterine adenomyosis as well as the endometrial carcinoma and the cervical carcinoma. Then adenomyosis is a non-neoplastic condition in which there is dislocation or extension of the endometrium through the myometrium, and the dislocated endometrium inside the myometrium do not usually undergo cyclic changes. The cause for this extension of the endometrium into the myometrium is unknown. In normal conditions, you remember that there is an endometrial cavity of high signal in the T2, the junctional zone, low signal, and the intermediate signal of the myometrium. Then in cases of adenomyosis, you will see that the junctional zone is markedly thickened, and the encroaching on the thickness of the myometrium. And this is the normal appearance of the uterus in the T2 weighted image showing the zonal anatomy. And this is the case of uterine adenomyosis, where you can see number one, ill definition of the junctional zone, then broadening and thickening of this zone, markedly encroaching on the myometrium. And also an incidental finding is the presence of multiple Nepothian cysts within the cervical canal. Uterine adenomyosis may present by dysmenorrhea, menorrhagia, pelvic pain, or non-specific symptoms, but the major issue here is the bleeding, as you know. This is the comparison between a normal appearance of the uterus in the T2 weighted image and the uterus which is involved by adenomyosis. Number one, you see that the uterus is significantly enlarged. There is a marked thickening of the junctional zone, and you remember that I have mentioned that the junctional zone more than 12 millimeter is diagnostic of adenomyosis, and here the junctional zone of a thickness 8 millimeter or less can exclude the diagnosis of adenomyosis. You remember the normal thickness of the junctional zone is about 5 millimeter. Then within this is the case of diffuse adenomyosis, and you see most of the uterine body is involved. Within the lesion, you can see some bright foci, which may represent heterotopic endometrium and cystic changes or hemorrhagic foci. Then these high signal foci on T1 weighted images are highly suggestive of adenomyosis. And this is a case of adenomyosis. The junctional zone is thickened, ill-defined, and you may see some foci of bright signal within. And of course, by hysterosalpingography, you cannot predict the possibility of adenomyosis. All what you see is some enlargement of the uterine cavity and irregularity of the uterine wall, which may be misinterpreted for intrauterine adhesions or synechia. But MRI is highly specific for diagnosis of this adenomyosis. Here you see the anterior wall of the uterus is markedly involved by this disease. There is considerable thickening, and you got the characteristic bright foci within the lesion. Also, you can appreciate the presence of a submucous fibroid and some blood clots within the uterine cavity. Sometimes adenomyosis present as a focal mass, and at that time it has to be discriminated from uterine fibroid. Uterine fibroid is of black signal in the T1 and T2 weighted images, and it has a characteristic well-defined margin whenever compared to the adjacent myometrium. But in cases of focal adenomyosis, or it's known also as adenomyoma, you can see that the lesion is ill-defined. It is black also in the T1 and T2 weighted images. And uterine fibroid may show some bright foci due to cystic or hyaline degeneration, and the uterine adenomyoma may show also bright foci due to hemorrhage and the cystic changes. Then, in order to discriminate between both, you may use the MR criteria of the defined border compared to the ill-defined margin of the adenomyosis. But usually, the discrimination is somewhat difficult by ultrasound. This is the appearance of adenomyosis by ultrasound, and you got some vascularity inside the lesion by a Doppler study, and these are similar findings for the leiomyoma. And by CT, CT is the least specific for imaging of uterine pathology, as you know, but it shows considerable benefits whenever evaluating fibroids by detecting the matrix calcification. And here you see that the uterus is somewhat bulky and there is a mass within the uterine cavity. And this mass is not for sure an adenomyoma or an leiomyoma or endometrial carcinoma. All can fit for this CT appearance. Fibroid, endometrial polyp, endometrial cancer, and the focal adenomyoma are in the differential diagnosis of this particular appearance. And this is the difference between uterine adenomyoma with ill-defined margin and hazy contour encroaching on the endometrial cavity, and the uterine fibroids, which are of more well-defined, well-circumscribed margins, whether they are big or they are small. But in the T1 weighted image, after contrast injection with fat suppression, you may got this appearance, which is almost similar to the uterine fibroid. Fibroid will enhance with contrast material. Also, adenomyoma will enhance with contrast material. And this is the focal adenomyoma of the uterus. And you see the thickening of the junctional zone of the posterior wall of the or posterolateral wall of the uterus, and you got the bright foci inside the lesion characteristic of this adenomyoma. Also, you see this ovarian cyst, which is an incidental finding. Focal adenomyosis or adenomyoma, this is of course a diffuse form, and you see there is involvement of the uterine fundus as well as the posterior wall and some of the anterior wall, showing the characteristic configuration. Then we came to this important issue, which is the endometrial cancer. This is considered the most common female genital tract carcinoma, and according to the literature, it is the fourth order site for cancer in female in general population after the breast, lung, and colorectal cancers. Then most of the cases are diagnosed after menopause, and this is the regular age incidence, which is in the seventh decade of life. And the main presenting symptom is, of course, a vaginal bleeding. And the most common histologic type for endometrial cancer is the endometrioid adenocarcinoma. But other histologic types can be seen in the clinical practice, like mucinous carcinoma, serous carcinoma, clear cell carcinoma, mixed and squamous cell type, transitional cell type, small cell carcinoma, and undifferentiated carcinoma. These are the risk factors and some of the factors which can decrease the risk of endometrial cancer. The risk factors include nulliparity, increasing age, metabolic syndromes, years of menstruation. The long years of menstruation may be a risk for endometrial cancer. History of breast cancer, the treatment using tamoxifen, which is one of the drugs used for in cases of breast cancer, which can, in most of the cases, produce endometrial hyperplasia and may lead to endometrial cancer. Then these are first degree relative with endometrial cancer, long-term exposure to estrogens, and postmenopausal high estrogen concentrations. And some of the factors which can decrease the risk include grand multiparity, and this is astonishing issue, which is smoking and oral contraceptive pills and physical activity. You should remember that smoking and oral contraceptive pills are included in the risk factors for cervical carcinoma. Then the appearance of endometrial cancer by ultrasound is non-specific. Then you see a mass inside the uterine cavity, which can represent a polyp or can represent an endometrial cancer. Then endometrial hyperplasia will appear of echogenic appearance on the ultrasound imaging, and endometrial thickening can be due to benign lesions such as hyperplasia or polyps. And the cutoff value of an accepted endometrial thickness is 5 millimeter in patients who are asymptomatic postmenopausal and not using this tamoxifen drug. This is the endometrial cancer by ultrasound and Doppler. In the ultrasound, you see that the uterine cavity is somewhat enlarged. There is a soft tissue mass within the endometrial cavity, and this mass appeared vascular on Doppler imaging. And CT has little to do with endometrial cancer. The only finding here is those seen in ultrasound. The uterus is slightly enlarged, and the cavity, the endometrial cavity, is filled by a polypoid soft tissue mass, which is less enhancing compared to the enhancement of the myometrium. Then this is for the differential diagnosis. This may represent an endometrial polyp, or it may represent a submucous fibroid or endometrial carcinoma. But dealing with patients after menopause, and the endometrial cancer should be put as a first possibility, and this lesion should be curated and biopsied to exclude this possibility. Then you remember that one of the most important pulse sequences for imaging of the female pelvis is the sagittal T2 weighted images. And an evaluation of the uterus in general, and in particular the cases with endometrial cancer, we need this particular pulse sequence. And sometimes you may obtain an axial oblique sequence which is perpendicular to the axis of the uterus for better delineation of the uterine contour and evaluation of the myometrial invasion. And many times you require to scan the upper abdomen to assess for the possibility of tumor spread. Contrast enhancement is needed here, and according to the literature, some prefer the dynamic scanning. I will I will show it to you now. Then the appearance of endometrial carcinoma on the T2 weighted images is relatively hyper intense compared to the intermediate signal of the myometrium, but appears hypo intense compared to the high signal of the endometrium. And you see a mass occupying the uterine cavity, maybe invading the uterine wall, and this is an important issue for staging of endometrial carcinoma. According to the literature, in order to differentiate this from a simple benign endometrial polyp, if you are able to see a central hypodense fibrous core within the lesion, and this may suspect the possibility of an endometrial polyp rather than an endometrial cancer. And the criteria of myometrial invasion is to see the high signal endometrial mass going deep inside the intermediate signal of the myometrium. And this can be appreciated also after injection of contrast material. And a smooth endometrial myometrial interface indicates that the tumor is not invading the myometrium. And we should assess myometrial invasion in at least two perpendicular or two planes, like the sagittal and the oblique axial images, for example. And assessment of invasion of the cervix is an important issue for the patient prognosis. And this is a sagittal T2 weighted image. You see an endometrial mass which has invaded part of the myometrium. And here we should state in particular if less than half of the myometrial thickness has been invaded, or more than half of the myometrium has been invaded, and this will change the staging of the tumor. And this is the dynamic study, where in the early phases after injection of contrast and late phases after contrast injection. Here you cannot see clear discrimination between the tumor and the myometrium, but in the later stages with diffuse homogeneous myometrial enhancement and the less enhancing pattern of the tumor, you can see the interface between the lesion and the myometrium, and to assess the degree of myometrial invasion compared to the normal thickness of the myometrium in the anterior wall of the uterus, for example. And these are the staging of uterine cancer. The stage 1 was previously described in A, B, and C, but now it's described in only A and B. And A represents myometrial invasion less than 50% of the thickness of the myometrium, if more, and this is stage 1B. And stage 2 means that the tumor has extended to the cervix. Stage 3 means that there is involvement of the pelvic or para-aortic lymph nodes, or there is extension to the vagina, ovaries, or the peritoneum, but no rectal or nor bladder invasion. Stage 4 means that there is rectal or bladder invasion, or there is distant metastatic deposits. And here is a series of MR images in the T2 weighted sequences, and you see a soft tissue tumor mass within the endometrium, which is not, as you can see in these images, invaded the myometrium. There is a clear interface between the tumor and the myometrium, indicating that you are dealing with stage 1A. And in this tumor, you can see after contrast injection and fat suppression, the tumor mass, which is not actually invading the myometrium, but using the diffusion weighted images, and here you can appreciate that the tumor is going slightly deep into the myometrium, and this is changing the stage into stage 1B. And this tumor has invaded the myometrium, as you can see in the sagittal and the coronal T2 weighted images. But you need the contrast images, and you may need the delayed phase images to show the interface between the tumor and the myometrium and to assess accurately how much of the endometrium has been infiltrated by the tumor. And this is also a superficial invasion by an endometrial cancer, which is representing a stage 1A tumor. This is one of the cases that is considered by the radiologist a difficult case to stage the tumor accurately because the myometrium has been stretched over the endometrial mass, and you may find some difficulties to evaluate accurately the invasion of the myometrium. But in this particular case, after surgery, the myometrial infiltration was superficial, indicating stage 1A. Here, in a case with endometrial carcinoma, invaded most of the myometrial thickening, but more importantly, you see a focus of the tumor invading the sacrum, the cervix, and this will represent a stage 2. Extension of the endometrial cancer to involve the cervix is stage 2. And stage 3, meaning that the tumor has extended into the vagina or in the ovaries or in the peritoneum. But this tumor is protruding into the vaginal lumen, as you can see, and this is stage 3B. Also, stage 3C, you can see metastatic lymph nodes. This is the endometrial cancer. This is the T2 weighted image. You see a big mass within the uterine cavity, totally infiltrated the whole thickness of the myometrium, and there are metastatic internal iliac lymph nodes. In this particular example, you see this is T2 and this is T1 post-contrast. A mass is present in the uterine cavity with more or less intact tumor myometrial interface. But during laparotomy, there were numerous tumoral deposits in the pelvic peritoneum, in the ovaries, and in the small bowel, and this will represent stage 4B endometrial cancer. And also in this particular example, you see a mass that has infiltrated the uterine wall, but in the same patient, you can see metastatic pulmonary deposits, and this is stage 4B. There are some pitfalls for the diagnosis of endometrial masses, including number one, the endometrial thickening due to benign disease like endometrial hyperplasia and polyps. And if the tumor is very small to be visualized, also this is one of the diagnostic pitfalls. In cases of postmenopausal uterus, the endometrial myometrial interface is usually hazy and it is difficult to assess myometrial invasion. Also, if the tumor mass is stretching the uterine wall, it is somewhat difficult to assess myometrial invasion adequately. If the uterine cancer is also associated with fibroid or adenomyosis, then you may got some difficulties in evaluation of the tumor extension. And in this patient with vaginal bleeding, and this is 90 years old with marked thinning of the myometrium in the postmenopausal uterus, the uterine cavity is filled by a mass, and the contrast enhanced fat suppressed T1 weighted image showed that the tumor is superficially located with no significant myometrial invasion, and this was confirmed after surgery. Then pitfalls considering the lymph nodes. Lymph nodes may simulate or may be indistinguishable from adnexal masses like the ovarian lesions, for example, bowel loops, and peritoneal deposits. Then the differential diagnosis of an endometrial mass by ultrasound or by CT or by MRI will include endometrial polyp, leiomyoma, focal adenomyoma, endometrial hyperplasia, intrauterine blood clot, and retained products of conception. Endometrial polyp is a benign lesion that can be sessile or pedunculated, commonly seen in patients on tamoxifen, and the polyps are largely asymptomatic but may present by bleeding, menorrhagia, and infiltrate. In about 20% of cases, polyps can be multiple. Then this is the appearance of an endometrial polyp, which is not differentiated from endometrial cancer by ultrasound or by sonohysterography. There is a mass within the uterine cavity, and yeah, I don't know if you can see the central scar or not, and this is not usually appreciated in most of the cases. The polyp by MRI will appear of intermediate signal in T1 and of low signal intensity on T2. And if you inject the contrast, it will show some contrast enhancement. This is the endometrial polyp protruding into the cervix. And this is endometrial polyp by sonohysterography. You see a mass within the endometrial cavity. And this is also an endometrial polyp in a fibroid uterus. The uterus is enlarged. It is studied by many interstitial fibroids, which shows low signal in the T1 and some contrast enhancement on the no. This is T2 weighted image with fat suppression, and you can appreciate the presence of a polyp inside the uterine cavity. And once more, this is the differential diagnosis of a polypoid lesion within the endometrial cavity by ultrasound or by MRI, the same differential diagnosis. And we came finally to the issue of cervical cancer, which represents about 4% of malignant disease and is considered the third most common postmenopausal gynecologic malignancy after endometrial carcinoma and ovarian cancer. The age incidence is about 40 years with another peak at 60 years of old. 80% of the lesions are of the keratinizing or non-keratinizing squamous cell carcinoma and 15% of the adenocarcinoma types. The risk factors include, you remember, smoking and oral contraceptive pills. Also, these are some of the risk factors: sex at any age, many sexual partners, poor genital hygiene, other genital infections, multiple malignancies in AIDS patients, and so on. Then the symptoms are, of course, vaginal bleeding, some vaginal discharge or dyspareunia. Then diffuse pelvic pain or back pain may indicate extension of the cervical cancer to the pelvic side walls. And the MRI technique for evaluation of the cervical cancer, we usually want to distend the vagina by the ultrasound gel, which will show bright signal in the T2 weighted images. And we will evaluate the pelvic floor muscles in the coronal T2 weighted images and the assessment of lymph node metastasis in the axial T1 weighted images. And usually in this case, we do not need to inject intravenous contrast material, but in endometrial cancer, we need the injection of contrast media, and also we need the dynamic studies. And here, this is the routine axial scanning, and this is the oblique axial, which is perpendicular to the axis of the uterus. Sometimes is helpful for assessment of tumor extension. The staging of cervical cancer is somewhat simple. If the lesion is confined to the cervix, and this is stage 1, if the lesion has extended beyond the cervix into the lower part of the uterine colpus or the upper two-thirds of the vagina, extension down is stage 2A, and extension above is stage 2B. Then if the lesion has extended more to the lower third of the vagina or to the pelvic wall, and this is stage 3A and 3B. An invasion of the bladder or rectum or distant metastasis indicates the stage 4. Cervical cancer is almost similar in signal intensity and MR criteria to the endometrial cancer. And you see a big mass in the cervix, which is extending into the proximal part of the vagina, representing cervical cancer. And these are the regions for lymph node metastasis, the obturator fossa, external, internal, and common iliac groups, pre-sacral lymph nodes, para-aortic lymph nodes, and the blood-borne metastatic deposits in advanced cases. And this is the stage 1A cervical cancer. 1A means that the tumor is less than 3 centimeters in diameter. If it is 5 or more, this is stage 1B. But you consider that the tumor is still confined to the uterine cervix. And this tumor measures about 2.3 centimeter in diameter, and this is stage 1A. And incidentally, you can see a very big uterine myoma in the posterior wall of the uterus. And stage 1B is the tumor which is larger than 5 centimeter, and you can see a mass in the cervical canal extending into the lower part of the uterine corpus. Then you may see interpret this as a stage 1B, or if you feel that it has extended into the lower part of the uterus, it may be of stage 2. Then stage 3A means that there is extension beyond the cervix into the this lesion has involved the lower segment of the uterus as well as the upper third of the vagina with mild parametrial invasion, which is difficult to be seen here, of course, but you can use the T1 post contrast fat suppression to see the invasion of the parametrial fat. And if you detected lymph nodes, as in this case, you see necrotic internal iliac lymph node, and you see bulky uterus with a soft tissue mass in the cervix, and you are in the stage of 3B. And this particular lesion, it has invaded the urinary bladder and extended to the pelvic side wall with metastatic para-aortic lymph nodes. Then you are in the stage of 4B. Melanoma and lymphoma are rare tumors involving the cervix, and they cannot be discriminated from the regular carcinoma of the cervix, but based on some signal criteria and the tumor bulk, you may be able to predict that this lesion is let's say melanoma if it has high signal on the T1 and low signal on the T2 images because of the presence of melanin pigments. And this is an example. You see a big mass which is involving the cervix and the upper part of the vagina. And on histology, it was proved to be carcinosarcoma with foci of melanocytic melanoma. Considering lymphoma, lymphoma is diagnosed by these criteria: large size, no invasion of the adjacent structures, no ulcerations, and you can add the presence of bulky, homogeneously enhanced lymph nodes. And if you see a big mass in the region of the cervix, and this mass is almost homogeneous with no invasion of the surrounding structures, and if it is associated with bulky metastatic lymph nodes, you may predict that this is lymphoma. And this is an example of a pathologically proved lymphoma. You should remember that primary lymphoma of the cervix is extremely rare, and lymphoma is usually secondary to a lymphoma present elsewhere in the body. And here is a big mass, which is of intermediate signal in the T1, some increased signal in the T2 weighted images, and the mass is bulky with no signs of invasion of the surroundings, and this was proved to be a lymphoma. In this particular case, you see a mass in the cervix and extending into the vaginal vault, and you see this big metastatic lymph node adjacent to the lesion, and the lesion was confirmed by biopsy. And this patient in particular has a history of orbital non-Hodgkin lymphoma, and he can interpret both lesions of the same pathology. And you remember the Nabothian cysts, which are mucus retention cysts within the cervix, and may develop secondary to chronic inflammation in the cervix. They are usually discovered incidentally, and they range in size from few millimeter to about 4 centimeter, and the signal intensity is usually uh, 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 low on T1 and high on T2, but some of these cysts may present high signal on T1 weighted images if they contain proteinaceous material. And this is an example of Nabothian cysts by CT and by MRI T2, T1 post contrast, and sagittal T2 weighted images. Of course, the best way to detect these cysts is the sagittal T2 weighted images, where you can appreciate the course of the cervical canal and you see the cystic lesions. The cervical polyps are almost similar to the endometrial polyps, but occurring in the cervix. They occur in the premenopausal woman, and they often present by bleeding. And these polyps may range in size from few millimeter to 3 centimeter. The lesion is seen protruding into the cervical canal. And finally, cervicitis is an inflammatory process affecting the cervix and is diagnosed usually clinically through the vaginal endoscopy. And you see that this is the difference between the healthy cervix and the inflamed cervix. Many of the organisms can cause this cervicitis, and of course, the diagnosis is performed without the need for imaging. This is the normal appearance of the cervix, and this is the changes which are interpreted of low-grade cervical intraepithelial neoplasia, but this is definitely a cervical cancer. هذا وبالله التوفيق والحمد لله رب العالمين.